Again, as it's been for the last couple of weeks, I think since the beginning of this, the PPE continues to be an ongoing problem. I think our primary focus has been and continues to be, and I think we're making progress on this. One is that it needs to be a precautionary approach. As I've said before, we are pushing the issue that because the patients are all commingled and the virus is, if you will, stealth in its early onset, and it should be maybe asymptomatic, but shedding it is twice the degree as influenza, that we have to treat it as if every patient in the hospital and potentially the healthcare workers themselves are positive and don't know it, and therefore if you're walking in and out of rooms, you may very well be either getting it yourself or spreading it to others. The only way to deal with that is to treat everybody as if they have it and to take a precautionary approach, which means you put an N95 mask on, face shield, gown, gloves when you're dealing with anybody. And if you're around the hallways and not with patients, you should wear a surgical mask. And also the patients themselves, when they're in and out of the room, should be putting on surgical masks just in case they do have it, that they're not giving it to anybody else. So I think that continues to be something that we need to push very, very hard. And I do think we're making progress, some of which the progress is being made not because of something that I'm happy about, but because I think the Holyoke Soldiers Home, which recently had devastating losses, I think in large part because the precautionary approach was not taken when the staff readily identified a person that had turned positive, immediately wanted all PPE on staff to isolate the person, put in the proper mechanisms to prevent the spread, and instead the institution, like so many, went right back on the heels of rationing the N95 masks and rationing the PPE, waiting for the crisis, if you will, but by doing so actually caused the very crisis that they were trying to avoid. So I think the nail has been hit on the head here, and we need to just continue to push it as hard as we can. And to that extent, and that includes us, the organization has, as I think folks know, put an order in for PPE ourselves, developing relationships with manufacturers to find really good products that we can, that to just as a supplement to what's going on. So I'm hopeful that hopefully, if there's no hijinks at the docks, that we'll see some first order of PPE that the association did by tomorrow, and if so, we'll begin distribution out to the bargaining units so that they will hopefully have more available N95s at a minimum. And we'll continue to look at the face shields, which we developed a relationship with a manufacturer in Boston on, and he's already begun distribution on those. And continued to work with a number of other groups, and the building trades for the New England folks and our local building trades folks are really, really helpful with us trying to make those contacts. You know, but beyond the primary focus of the PPE, I think this week, we mentioned it last week and we've mentioned it in our recommendations to the governor, is that, you know, looking at the time frame of how this virus is going to escalate in terms of patient population, we have probably about a week before what we consider to be the surge here in Massachusetts, where we see the peak of the number of patient admissions. So we really have about this week to go ahead and train up all available staff for the expansion of the ICUs. But in order to do that, the institutions have to be very clear about what space is going to be used for additional critical care beds, what staff is going to be used, and to train them. And I think a lot of, not all, but a lot of the institutions seem to be putting stuff on paper, and that's not going to help us in the moment. We don't need it just on paper. We need it communicated. We need the space to be at least reviewed to some basic criteria through the Department of Public Health, so it has adequate ventilation and whatnot. And we also obviously need the staff to be well aware of where it's going to be and how it's going to be staffed, so that those individuals that we're recruiting into these expanded areas may have an opportunity to go ahead and buddy system up to existing ICU staff, begin to get comfortable with it, have folks that they're going to work with and can be go-to people if they should run into problems. That is going to dramatically increase the comfort level as these patients arrive, rather than trying to do it in the moment. So really, it's not just a few institutions that have been doing it, but all of the institutions need to be doing this. And I very much hope that we turn out to be wrong. If it turns out that we didn't need all the additional ICU space and all the additional training, well, that'd be the best case scenario. But if what we're seeing is happening in New York to be any indication of what we should be prepared for, we should be taking whatever time we have and luxury we have, that not being in that circumstance, to be as prepared as we possibly can for it. So that includes additionally understanding best practices that are available to us. And I also think the reality of developing ethical committees is really on our doorstep now as well. What I mean by that is that, you know, everything we've seen from the other states and the other countries is that we're not in a situation where we were prepared with the available resources for pandemic level admissions of this nature, particularly in critical care, those needing ventilated beds or critical care. And as a result of that, you know, there may not be all of the resources necessary to treat all of the patients in the moment that they arrive, and that makes for extremely difficult decision making. You can't just leave it to a few people or just a haphazard approach about if that comes down to reality, how will you decide? Now is the time, just like being prepared with the critical care beds, to go ahead and put committees together on each of the units where people may face this. If there's a circumstance where you feel that, you know, a patient really will not be able to deal with being vented and intubated, well, how do you make that decision? And who is part of that decision, and who do you speak to? Those committees really need to be made up of frontline people, incorporate clergy and anyone else that is, you know, relevant to the care of the patient, so that you and those committees would already be known, not like, you know, trying to slap it together in the moment of a decision's being made, but rather to know who that committee is going to be. And therefore, if I'm taking care of a patient that I really feel based on my care would have a fighting chance if they were giving a certain treatment available, I like to be able to make that case before that committee as a group. If I don't succeed, I may not succeed, and maybe the larger decision's made that the patient's not going to be intubated or whatnot. But I will have had the opportunity to have my voice heard as an advocate for the patient because I am directly involved in that care. If we don't do that, it's not good for the patient, and it's certainly not good for the people who have to implement or not implement care, which will have ramifications for many, many years to come after this is all over. I think best practices, you know, we're in this moment where normally you would look at somebody doing many clinical trials, and it would be replicated multiple times, and we would review it. There would be peer review, and then it would come out in various journals, and, you know, maybe somebody would pilot it, and like all that's thrown out the door right now because we're all up to our eyeballs in a pandemic, and people are looking for any answers that might work. So a lot of the different materials and procedures being used are really being developed on the fly as a result of experience in China, in Italy, in Spain, and they're sharing that information. And even here, as people are short on PPE and they're coming up with innovative ways to make do, I mean, that information needs to be shared and communicated. Isolating it within a facility is not helpful to anybody. We need to be going ahead, and I think a lot of people are getting on social media doing it, but they should be ways and avenues for them to do that readily among and between the different facilities. A couple of case in points where, you know, we see readily the anesthesia folks using this plexiglass box now, and it's now become kind of common to see it around the different hospitals around the country, and it's basically utilized in order to avoid a large spray of virus droplets, small virus droplets, as a result of the intubation. When we're so short equipment for PPE, trying to limit the exposure to people that are involved in the intubation. And it's simple, it's easy, I think it's relatively easy to make, but it's been shared on the internet. There should be a way to share that more clarity. The specifications, there should be sort of an open process in which the specifications are readily shared so that anybody and anybody available who could manufacture this or make it available to all of the institutions would be able to do so. The same is true for other types of materials that we're making or procedures that we're doing. We're now seeing that a lot of the institutions are putting patients prone in a swimmer's position because they're saying that, you know, this is actually helping, like a lot of acute respiratory distress syndrome patients, putting them prone is actually helpful to expansion of the lungs, and increasing oxygenation. So a high flow oxygen concentration with putting the patient prone may actually result in somebody avoiding having to be intubated, and that would be better for everybody. So, but all of those kind of like open sourcing, you know, that you would do in the computer and IT, we need to open source the best practices that folks are coming up with through Europe and Asia and whatnot, all the way through the United States and elsewhere. I think one in particular is, this is not specific to us as nurses, but as we look around, you know, sometimes I think it's incumbent upon us to say out loud what everybody else is thinking. And that is, I think on the school issue, so many of our folks, it's 96% female dominated, and the kids at home and schooling and everything else that they're working with too. In fairness to the kids and in fairness to the families, I think we should just stick a fork in it here and make it clear that we're not going to have an in-person school year again, you know, at the end of this year. It's going to be all have to be virtual. We will not be bringing the kids back to school this year. I think it's the quicker that the state goes ahead and just makes that decision, I think the better for everybody, that they know that's going to happen and they can make plans for that. And the reason why we really can't see that is obviously we know the kids are the ones with the least symptomatic in terms of the virus, but they shed it, you know. And so if things go, if we flatten the curve, if you will, if we make things tolerable in the moment, and then we only open it up, the school systems, to the kids all going back and then going home again, we risk all of the work that's been done to try to slow this virus down to potentially creating another spike again. So as much as I realize, you know, it's hard for everybody and you really wish it were different, I think it's just a bad decision in terms of a public health. So it's easier just to tell everybody that now and let them deal with it than to make people wonder week after week after week what might be happening. Yeah, it's been a long 4 weeks. I'm sure it feels like a lifetime right now to most folks, and there's a lot of anxiety I know out there, but I think people are doing an amazing job in a very difficult circumstance, and one that we really should not have been placed with as we have with the lack of equipment and training. But it is where we are, and we're doing the very best we can. We continue to try to make that circumstance better. But I would say one thing is, for M&A nurses, and you're in your bargaining units and you're used to being able to address issues by having a committee meeting and a bargaining unit meeting and coming up with a plan to effectuate it, and all our normal mechanisms seem so difficult to be able to do. But I want you to know that we've switched up quickly here, and that every single director and many of the associate directors have Zoom capability. So we're encouraging the ADs at this point to do weekly Zoom meetings with the committee and to open that up to the bargaining units as well. There's been a lot of communication through phone, conference calling, email, and people are fighting back on the issues, and they are prevailing. And so in each of the fights that we've seen across the state, whether it be housing, whether it be people bringing their own PPE and being threatened, and you know, we're prevailing on that too. And now JACO's put out a statement saying that yes, if you have your own PPE, you should be allowed to wear it. I think we're prevailing on a lot of these battlegrounds by use of press and communication, social media, whatnot. So don't step back at all. If anything, step up. And we'll, given that this is going on for quite a while now, we'll be adding the Zoom technology into it so that you can have more face-to-face time with each other. And also the M&A, I believe, is going to start up a FaceTime process where we can have an open kind of source mechanism of having a conversation about what's going on across the state as well, and some links as well for folks to be able to get some support, because this time is very, very stressful, and I certainly know the types of conversations healthcare professionals have with each other is very different than the conversation that you feel comfortable having at home, and we need to create a space for that to happen and support for that to happen. So all of those things are happening here at the organization, and we put into place so that you can be as an effective voice as you have always been in every battle placed before you. I have been in touch with my colleagues in New York who are going through obviously a very difficult time. Queens is really the epicenter, it seems, of the virus itself, although all of New York City is dramatically impacted. They're receiving some equipment now from China and some from other sources, and everybody's aware of Mr. Kraft going ahead and getting a plane load of N95s delivered directly from China, and some of those went to New York City. But I asked more importantly what it was looking like on the inside as they continue to advocate for themselves as well. And I would tell you, to give you a sense of it, is that here's an example of one major Manhattan hospital that is on the more Upper East Side. All of the patients that are in that hospital, probably 90% of the entire hospital, which is a tertiary care acute center, is all 90% COVID patients at this point. Nearly every major unit has been converted to an intensive care unit at this point in time. They're running out of space, and they're actually contemplating at this point using the auditorium and the cafeteria for additional space for patients. Now keep this in mind, that New York also has in Central Park tent set up for this. They also have the Javits Center, which has been expanded up to, I think, 3,000 patients now, and they have the comfort shift for the non-COVID patients to be transferred to. So with all of that additional capacity, to give you a sense that 90% of the patients in a major facility now are all COVID, and the vast majority of the units have been converted to intensive care units at this point. So while we certainly hope not to be a New York situation, I think we're foolish not to be readily prepared for it, and it's better to be hoping, for the best, but preparing for the worst. And that's why I had mentioned earlier, let's train everybody up and identify all the space that we need, and let's be as prepared as we possibly can be. And if any luck, maybe we won't be in the same situation. But if we are, we will at least be able to know that we were well prepared to try to deal with it as it came to us.